Good morning, Chair and members. Again, Renee Malo, Deputy Director with the Department of Healthcare Services. And I just want to touch on a couple of the statistics regarding the program and the populations that we serve. So in 15-16, we're estimated to serve approximately 12.5 million individuals here in the state of California, as Director Ken had mentioned. And looking at that population, individuals between the ages of 19 to 64 represent about half of that population. And then of the individuals that are enrolled in our program, approximately 77% of those who reported ethnicity reported that they were individuals of color, for those that did report on their application. And looking at enrollment status, statistics for African American individuals in our program, we cover approximately 9% of those individuals in Medi-Cal. And as of June 2015, of the 5.6 million male enrollees, 3.7 million of those individuals reported an ethnicity other than white, and that was approximately 66%. We do have various pathways in which individuals can become enrolled in the Medi-Cal program, and one pathway was afforded to us through the Affordable Care Act, and that was through our Hospital Presumptive Eligibility Program. Based upon enrollment data as of the end of July, a total of 19,000 individuals came in through the Hospital Presumptive Eligibility Program, and of that number, approximately 58% were men. And of those individuals who had reported ethnicity, 59% were individuals of color. And the majority of those individuals that are coming in through the Hospital Presumptive Eligibility Program between the ages of 19 to 64 were the majority of those individuals. And again, serving those individuals between that age, Hispanic individuals were 54% of that population, and then African American were approximately 12% of that population. Again, through this program, individuals have, based upon self-attested information, the ability to have access to full scope Medi-Cal services until such time that they file an application through the Medi-Cal program. And looking at our specialty mental health services, again, this is a very important component of the program, and this program is operated at the local level. And so in looking at individuals for utilization of services for fiscal year 15-16, we're serving children between the ages of 0 and 20, because for kids in Medi-Cal, we go up to age 21. We're looking at serving approximately 277,000 individuals, and then for adults over the age of 21, approximately 236,000 individuals. In terms of the ethnicity, we're looking at serving approximately 67% of those individuals that have reported on their ethnicity as other than white. And again, of that population, 33% are Hispanic, and just under 16% are identified as African Americans. Within the population of serving for individuals that are seeking specialty mental health services, again, those services are delivered through county mental health programs, and those programs are available statewide at the local level. And historically, of the children that are receiving specialty mental health services, males make up almost 57% of that population. And when we're looking at individuals that are served, again, of the males, 68.4% report an ethnicity other than white. Hispanics do make up the largest population for those between the ages of 21 and 59. And then African American males make up the largest group for all youth ages, served between up to the age of 20. So with that, I will stop with my comments and turn it over to my colleague, Will Lightburn, or if there's any questions for us. Thank you.
Thank you. We'll do questions and comments from members at the end of the presentations of all the panelists. Mr. Lightburn.
Thank you. Chairs and committee members, I'm Will Lightburn, Director of the Department of Social Services. Among the programs that CDSS operates are the state's public assistance programs, CalFresh, CalWorks, that serve upwards of 6 million people, and the home care programs serving about 500,000 people at home. But primarily today I'm going to focus my comments on the child welfare and foster care program. But happy to answer questions in any area of departmental programs you might have. I provided the committee with some data relative to ethnic representation in the child welfare foster care system over the past 10 years. And I'm not going to walk through it chart by chart. I just want to sort of capture the major features of it. Basically, among communities of color, black children are significantly represented at a higher rate, both in terms of the allegations made to the child welfare system of maltreatment and then substantiations and entries to care than other groups. Native Americans are also highly disproportionate in terms of their rate of referral. Then Latino youth are closer to the level, almost identical to the rate of referral substantiation of entry of white youth. And both of those are proportionate to their percentage in the overall population. So there's nothing surprising in those. And Asian Pacific Islander youth are somewhat underrepresented in the case flow. In terms of the numbers of youth in care, the only thing that's probably, well, two things are noteworthy. One is the proportion of African American youth has been declining since 2004 quite sharply. That's a result of the implementation of the guardianship program. So a large number of youth have left care to be in care, to live with guardians. The other somewhat emergent trend, and I'll speak more about it in a minute, is that we're starting to see an increase in the numbers and percentages of Latino youth just in the last couple of years. Partially that's a result of the fact that in 2011-12, the state began implementation of extended foster care, referred to as AB 12. So 18, 19, and 20-year-olds who were not previously in care could opt into care. The participation rate actually has been surprisingly high. About 70% of the youth who are eligible to remain in foster care at their own choice are choosing to do so. So that produces a somewhat upward pressure on numbers. But there are other factors I'll mention in a moment. One comment I just want to make is about the relationship between foster care and the state prison system. At various times in the past, different numbers have been circulated and take on sort of legend-level proportions. As high as 70% of kids in the state prison, men in state prisons, came from foster care. In truth, we've done a very detailed data match with CDCR to look at the entire population that we can track in a comparable period, and something like 28% of those who had record with CDCR had a prior involvement with the child welfare system. And given that it's a much smaller number from the prison system, about 130,000 for the 15-year period, as opposed to 1 million children from the child welfare foster care system in that period, in fact, what we see is there's a much lower likelihood of children moving from foster care to the justice system than sometimes has been suggested. However, I would note that of those who have made that link, about 60%, their last placement was in group home care, rather than for the overall population, only a child welfare population, only about 20%'s last placement was in group care. I sort of gave you a quick sheet with the major initiatives that are underway intended to address these trends. The Partnership for Permanency, which has been modeling service partnerships in 4 counties, focusing on both African American and Native American families. The Latino Practice Standards effort that we kicked off 2 or 3 years ago. Partly what drives this is, although Latino children are not disproportionately now in the system, they are a majority of those in the system because they're a majority in the population. And they will probably increase as a percentage because behind the data, there is lower involvement from Latino families where the parents are foreign born than for those who are U.S. born. And so as that population shift continues, there will be some upward pressure. So we were developing particular approaches for the counties to operate. Very quickly, the KTA settlement has sort of a whole strategy around embedding specialty mental health services in with child welfare for children who meet medical necessity and have had multiple placements. The Wellness Project, which is referred to sometimes as the waiver, which now about half of the state's caseload is under this, as Director Kent described the sort of the deal we strike with the feds. We will flexibly serve to try to reduce bad outcomes. You, in turn, assure certain funding levels. So that expanded last year. And then finally, the major piece I just referred to is the Continuum of Care reform effort, which is pending as AB 403, and which really is our major focus to shift the care of youth away from group care and into relatives and family-based care in the community. So with that, I'll stop and see if there are any questions.
Great, thank you. I want to acknowledge the presence of Assembly Members Garcia and Assagian. Assemblymember Wilk was here earlier as well. We can open it up to questions or comments from members for this panel. Assemblymember Brown.
Thank you. Dr. Smith, I think you were, it was either you or Mr. Miller, that spoke about a release of RFPs that is going to happen soon. Can you speak a little bit more about that?
Sure. The California Reducing Disparities Project is a project that actually began in what was then the Department of Mental Health prior to the merger with the Department of Healthcare Services. The overarching goal of the California Reducing Disparities Project is to actually fund and build capacity for evaluation of existing community-level mental health projects, and in particular in certain subpopulations and ethnicities, and that includes African Americans, Latino, LGBTQ. Help me out, Jamal.
Native Americans.
Thank you, Native Americans.
Yeah. And
so I just go through the litany. 5 targeted subpopulations. At any rate, the point being, rather than actually funding the projects, these are projects that already exist that have the communities in which they are being practiced actually believe strongly that these are effective practices. What's been missing in terms of actually helping to get additional funding for those is good, strong evaluation. So creating that evidence base, and that's the intent of the California Reducing Disparities Project, is to try to both provide the evidence base by doing actual evaluations, but also providing technical assistance to the community-based organizations that are doing the work, so that they can then go on with those evaluations, and that will help their ability to demonstrate their effectiveness and to get additional funding.
The reason that I asked that is because my community is one of those communities that really needs to make sure that we get some of the funding. Mm-hmm. And as I see it, everything that comes from Sacramento back to the communities comes through a RFP process. So if your community doesn't really have the capacity, mm-hmm. we always get left out. So I want to make sure that whenever you're looking at those projects and you're looking at the RFPs, that you look very closely at the 47th Assembly District. I say that it's the same in the Central Valley as well. Mm-hmm. But in some communities, there is just an absence of this. The other thing is that you said that this would build on the projects that are already there. One of the other things that I've heard and I see happening is that government doesn't want these organizations to depend on the funding. Mm-hmm. So what they'll do is they'll get them started, and they'll get them, right where they need to be, and then they pull all the funding out from them. What can we do with this process to stop that from happening? Thank you.
Excellent comment and question. When we put out our RFPs for public comment, we received over 800 comments from a variety of communities in the state. And one of the key words that stood out and values for us was sustainability, in that this is a demonstration project. And a big part of why evaluation is important is to demonstrate that culturally congruent work in our communities, that it works, and to encourage collaboration and partnership with local mental health departments. So we've been thinking about what that 2.0 phase looks like beyond the next 4 to 5 years. But my second comment is that we, by virtue of the comments that we've received with deep stakeholder engagement, we've administratively augmented our procurement practice around administering grants and contracts to be more accessible and attainable. Much of the feedback, and I've seen it in my role, around those who often get contracts or grants are typically those that have a monopoly to some extent on the process. So we are proud, and I think many of our stakeholders would attest to our ability to make the RFP process more accessible. And our mantra kind of has been, we want to fund the losers, and not in a pejorative way. You know, we want to include more communities in the process and build out this work beyond just a demonstration project when the funds typically expire and the great work tends to not be continued.
From the department's perspectives, all three that are represented here, do you have access to the right data that you need to drive the solutions that are necessary? And there's been discussion here in the legislature about disaggregated data and collection of data in different categories. To the extent that having the right data at your fingertips to drive the solutions that are needed, do you think you have that?
So let me just speak from the perspective of the data that we use primarily in the Department of Public Health is population-level data. And so we have a lot of data. Most of it's in a form that's usable, but not all of it. And so we're actively involved in the open data portal and actually we're increasing the resources right now that we have to access additional data sets. So we have data that comes from our programs. Where, in my opinion, where the real value comes is when we can start sharing information across programs, where we get a much more comprehensive picture from the entire perspective of Health and Human Services of what's going on where. You also increase numbers that way. The challenge is always having if the numbers are too small, my preference is to actually have data at the neighborhood level, because it's there that you can understand in a community, and I come from a background of working in community health in the community. You need to nobody has all the resources they need to do everything for everyone. So you really, in order to target your interventions to where they're most needed, you need to have information not just about the need, but also the resources and where they're going in your community so that you can make better decisions. So we're working very hard at the state level in the Department of Public Health, both to use the data ourselves, but to make it accessible for the local health departments as well, so that they can use it to inform their practice.
By and large, I'd say that we have good data access. Certainly in the last year, we've developed a global data sharing with the Department of Healthcare Services and Department of Social Services around child welfare, so that medical and caseload and down to the individual child information is now being shared. The data piece that we're looking for now as part of AB 403 and Continuum of Care is a really sort of robust, repeatable assessment of children, so that we can not just assess children at the point of entry into care, but on an ongoing basis, have very accurate measures for where they're making progress, where they may be having difficulty, what additional services are needed. And we expect that to be something that is realized in the next year.